Hello, I'm Reggie Turner, and I'm here with Terrence Moore and Jim Miller. The FlipSide starts right now. Welcome to the show. Tonight we're with Ernesto Lopez, Chief Executive Officer for Hospice of Washington County. Ernesto, welcome to the show.
Thanks, great to be here.
First, Ernesto, tell us a little bit about your role at hospice and about hospice itself and what it means to our community.
Sure, I'm the Chief Executive Officer at Hospice of Washington County. I've been in this role for a little bit over four plus years. And Hospice of Washington County is a nonprofit hospice organization that also has a palliative care program. And we serve Washington County and also, since last year, Franklin County as well.
Excellent. Terrence?
Is there any relationship with the local hospitals or any other organizations in the community?
So we work very closely with all the healthcare providers in the community, especially the hospital. Emeritus and Hospice of Washington County work very closely in transitioning patients from those settings into hospice care. We work with the nursing homes in the community, all of them. We work with home health care as well. So there's a tight integration of work and cooperation between all the healthcare entities in Washington County.
So they actually are recommending your services, for lack of a better term?
Sure. A lot of times the conversation around hospice care is initiated by the physician, whether it's in a hospital setting, it could be in a nursing home. Sometimes families hear about hospice and they reach out to hospice to learn more about our programs, about our services and so forth. But that communication is critical in order for us to be able to onboard and educate patients and families about our services.
So talk to us about the definition, the scope of this palliative care that you provide.
So overall, there's a lot of confusion between what's hospice and what's palliative care. Some folks sort of mix both terms together, and there is a differentiation between both. Hospice is a defined period of time, which is really around end-of-life care. These are patients that are terminal, and the way that we've defined it in the industry is anybody who has 6 months or less to live, as defined by a physician. Typically the primary care physician and a hospice physician make that determination based on the patient's symptoms, what's happening with their health, their history, and so forth. Palliative care is a whole other grouping of patients. These are patients that have serious illness. They have multiple problems, health problems that they're dealing with on a regular basis, and they're not terminal, they're not ready for hospice care, but they need a lot of support. And so we have a outpatient clinic where a physician and nurse practitioners see these groupings of patients and help navigate them. They work very directly with their primary care physicians, with their specialists, in order to manage their care. It's sort of like an additional layer of care and coordination that a lot of times patients really need. You know, they're individuals that have multiple issues, and a lot of times they get sort of lost in the stream of different healthcare resources, and they don't know where to go, and they may not be able to get into their doctor's office for months or weeks. And so this is where palliative care is a great resource. We work very closely with their doctors to make sure that we're all on the same page and that patient is following the appropriate trajectory and they're getting the care and support that they need.
So I'm not trying to hog this segment.
Oh, good.
So the care that is provided, oftentimes that's in the home, is that true?
The majority of the time, actually the great majority of the time, the care that we provide through hospice is in a patient's home or anywhere they call home. It could be in a nursing home if they live there, an assisted living facility, a prison. I mean, we actually take care of people that are homeless. We'll go out to shelters. And so that's the philosophy of hospice is based around that, we're bringing healthcare medical support to you wherever you are.
And your practitioners, your providers interface then with the primary care or other people that might be working on the same case?
We have to work very closely with them. That's the key of true care coordination is you have to work with those primary care physicians, those people that have been treating and managing that patient. They know that patient much longer than we do. And so that coordination is key to making sure that patient is getting optimum support and the right care that they need to be able to treat and manage their symptoms.
Yeah, and I like the word care coordination because it's a team.
Right.
You know, there's relationships that have to be there, and there's capacity constraints that happens sometimes that it seems like hospice makes sure the care stays in care, right? How's that been during COVID?
Tough. Like many healthcare providers, this has been a real challenge for all of us. And you know, part of what a lot of people don't realize when COVID started, you started seeing everything in healthcare changing. You know, restrictions and you know, you started seeing a grouping of patients that were coming into the hospital, and you started seeing other types of patients that weren't really being seen or treated. Lots of protections around healthcare workers and so forth. What folks didn't realize is that for hospice, that challenge was even greater because our staff are going into people's homes. That's where we provide care. So in the middle of COVID, you know, you may be going to a hospital where everybody has to wear masks, people have to be, they're protected, you know, you can't bring visitors. Well, we're walking into a home where there could be 7 or 8, 9 family members, and our folks are providing direct care to those individuals. So from day one, we've been very assertive in making sure that our staff are wearing N95 masks, respirators. We've got gowns and shields. So from day one, we've been operating in a very protective environment for them as they're going into these spaces where it's uncertain whether there's COVID there or not, and a lot of times there is. So it's been very challenging, but you know, for our staff, it's you know, it's a passion and a calling for a lot of these individuals that do this each and every day. Somebody asked me just today, you know, how is it really difficult for people to work in hospice, and you know, is there a way to find joy in the work that they do? And I said, absolutely. I mean, these folks that work for us, they've been working for us for a long time. There's a tremendous amount of just value, personal value of working with individuals that are grateful for the type of support and care that they're being provided. But under these circumstances with COVID, it's been even harder. And so, you know, like many other healthcare providers in the community, we're seeing, you know, challenges, we're seeing burnout, we're seeing, you know, folks that are becoming disengaged just because of the monotony of being in these environments and having to work with these restrictions. So we're dealing with it just like everyone else is right now.
And your staff, from a staffing perspective, how many, the medical providers, they work for hospice, is that true?
Yes, they do. So we have several physicians on staff, and we have a physician that covers our inpatient facility, Dewey's House. We have a physician that covers our hospice out in Pennsylvania, in Franklin County. We have a physician that oversees our palliative care program as well. And so we have several physicians that work with us. Physicians are a critical part of providing hospice care to patients and palliative care as well. So we have a really strong team of docs on our team here.
Excellent.
How many patients, on average, are you providing service to on a yearly basis?
So on actually on a daily basis, we see about 230 to 240 patients as our census for hospice, and for palliative care, it's about 250. So we're touching about 500 lives every day in the community.
Do you see that number increasing? Are the trends of that number changing at all, or where are we with that?
You know, the trends have been pretty stable. I think that what we're seeing in the industry is that there hasn't been tremendous growth in hospice care overall. There's been sort of a stable, sort of up and down throughout the last couple of years, but we have done a really good job of touching and connecting with those patients that need our services. One of the measures that we use in our industry is hospice utilization rate. And that is the number of patients, or the percentage of patients that actually are getting hospice that need hospice care, based on the number of deaths in each community. And so we are at about 56%, which is pretty fantastic. The national average is about 45. And so we do a really good job in this community of getting to the patients that need our services. I would say that, you know, there's always opportunity for more patients. A lot of patients decide not to come to hospice, or they decide very late. You know, they're in the hospital, they're in the intensive care unit, and it's really, there's no opportunity for hospice to come in and really help that patient. We can help families afterwards with bereavement support and counseling, which we do for all our patients at no charge. But, you know, a lot of our patients sometimes, because families are wanting to be more assertive, aggressive in treatment, and I think that that's one factor that COVID has played a critical part is, I think with COVID, families have been more assertive of wanting to treat patients a little bit more longer than they probably would have, especially if someone is having COVID-like symptoms and they're terminally ill, and then you're adding this additional complexity on top of that, then you're seeing families being a little bit more reluctant to call hospice and wait it out and go through the treatment process.
Do you feel like there's some families that just, or even patients that really are kind of denying the inevitable for some of these terminally ill individuals?
I think it happens across the world, and you know, in our society, it's one of those things that we've always been challenged with. You know, and if you think about it, a lot of this, yes, it could be centered around families, but also healthcare providers play a critical role. You know, physicians are designed to want to treat, to cure, to make people feel better. And that's what drives how they treat and manage patients. A lot of times it's difficult, you know, to have that conversation with a family or a patient, say, hey, there's nothing else I can do for you. You know, we've done everything we can do. That's a hard conversation to have as a physician. And a lot of doctors aren't comfortable having those conversations. And so because of that, we see delays in getting these patients into hospice care earlier than they should. Sometimes families are very insistent on wanting to, what else can we do? What else can we try? And you know, ultimately, you know, we try to focus on what does the patient want? You know, what are the wishes of your loved one? Because ultimately, you know, that's what we should be leaning on. What does somebody want? You know, how do they want their care to be transitioned? Do they want to be in a hospital? Do they want to be going to these clinic visits, you know, every few days and jumping on an ambulance? And so that's where we come in, and we're able to help families understand that there's another way. You know, there's different ways for you to still have the support that you need, the medical support. Because a lot of people think, well, if you're in hospice, there aren't any physicians involved, and you know, people are just, you know, providing pain medication. Well, it's a lot more than that. You know, we're working very closely to monitor those symptoms to make sure these patients are comfortable, that they're getting what they need. And a lot of times, what we do, we design a custom plan for each patient. And some patients, you know, they want certain things in their care, and others don't want other things. And so we're very specific about, you know, setting that structure when they come into our program. You know, what is it that they want? Do they want, you know, nursing aid visits on a regular basis? Do they want a chaplain to come in? Do they want to talk to a social worker about advanced directives or planning, you know, after? There's so many different components of that. Some patients, you know, just want the nurse to be there. Others, you know, they want the entire team to be there on a regular basis, including volunteers. And volunteers are also a big part of what we do. A lot of our volunteers go into patients' homes and spend time in companionship and support with our patients that are dying, and it's a huge benefit value for them to have this person who's volunteering their time and energy to be there, you know, just to be a companion for them.
So there are many things that I want to dig into that you just said, but let's start with the last thing you said, which is the volunteers. Mm-hmm. Where do these volunteers come from? What is the training that they have or get through hospice or some other source? How does that work?
So volunteers have to go through pretty extensive training.
Sure.
We provide that training for them. A lot of these volunteers are actually family members of patients that we've had. You know, a lot of folks are coming back to us because they want to give back. They enjoyed the experience of getting that support, you know, during that very difficult time, and they want to find time, you know, to be able to help other patients. And so we have about 200 volunteers, active volunteers in the community, and they do a number of different things, not just, you know, helping with patients. They, you know, these folks, we have people that come and answer phones, that are helping us, you know, create flower bouquets for patients. I mean, there's just a long list of different things that volunteers can do. And typically what we ask is, you know, what is it that you have a passion for? What do you want to do? How do you want to help? And we try to fit them into different spots within the organization where they can provide that kind of support.
So for some families, this is a way to pay it forward because
Absolutely.
of the services that they received.
Absolutely.
Wow, that's cool.
It's a pretty big percentage. You know, almost every volunteer I speak to has a story, so some
I'm
connection.
Sure they do.
And as in the community, you know, for you and your staff and those volunteers, we're thankful because, you know, with hospice, you said 6 months. So this past holiday may have been the last holiday a lot of your clients actually will ever see. And they spent that time, and a lot is going on. It's just in the environment outside of work as well. So how does that been playing on some of your staff and volunteers as well? What was that impact, and what are you kind of doing what can you do right now to address it?
So a couple of things. The first thing I would say, this is probably the hardest time for people to actually call hospice for help, because it's the holidays, and a lot of folks that are hurting and are needing that support are going to be a little more hesitant to call hospice. But it is an important part. You know, it's this holiday season is important, as you know, they're spending, as you said, their last Christmas or last Thanksgiving with their loved ones. You know, our staff is all about creating experiences, and so what can we do to help those families connect better? What kind of framework can we create for them, or environment for them to be able to spend those last moments or those last days, weeks, whatever time they may have left? So some of the things that we do, we have a wish program, sort of like a Make-A-Wish program. We do the same thing with our patients. Sometimes our patients want to do things that they couldn't do or they couldn't plan for. And over the years, we've done some pretty interesting things. I mean, there was one patient a few years ago that his dream was, and he was an old Army vet, he wanted to ride in a tank. So that's the wish that came to our table. So where are we going to find a tank in Washington County? Well, believe it or not, we found one. And so we had a local resident who had a tank. You know, it was a modified tank, and he let us borrow it. He came in, brought it in. The patient was able to sit in the tank and rode around the neighborhood. And so those are the kind of things that we do that you know, you're not compensated for that. You're not, you know, it's not something that we have to do. It's something that we want to do, because it really enhances that experience for that patient and that family, you know. And sure, it got a lot of media attention and lots of pictures, but the most important thing is just to, you know, see the look on their eyes, see those pictures, and that's a memory that they will always hold. You know, that they'll always have, you know, of that last opportunity to jump on a tank like he did, you know, 30, 40 years ago, and be able to do that here before they passed away. Those are the kind of things that we do during the holidays. You know, we focus on, you know, meals. A lot of times families are looking for a special meal, and you know, they're very tight financially, so the program allows us to be able to go out and say, well, tell us about what you'd like to have, and we provide that for them. So, you know, we couldn't do any of that if it wasn't for, you know, all the support that we get in the community, the philanthropic support that we get from Washington County that are funding these programs, and they make such an amazing difference in their experience and their time in hospice. So things like that we try to integrate during the season. We get a lot of requests like that during this time, because, like I said, it's just that time of year where people are looking to do that last thing. It's the last holiday. What can we do to be able to, you know, spend valuable time with our loved one before they pass?
Excellent. Ernesto, you mind staying with us for another segment? We want to pick your
Sure.
brain a little bit more.
Would love to.
Excellent. Next up, stay with us. More with Ernesto Lopez when we come back. Welcome back. We're still here with Ernesto Lopez, the Chief Executive Officer of Hospice here in Washington County. Thank you for staying with us.
Absolutely.
First, if you can tell us, how are you funded?
So there's several methods of funding for the organization. Hospices are primarily funded by Medicare and Medicaid. So that's the primary funding mechanism, but all the major payers, commercial payers, do accept hospice as well. But we also, you know, philanthropy is a big part of what we do, and we mentioned in the prior segment about some of the programs that we do that are only possible because of the goodwill and because of the generosity of the community. So those are the major funding mechanisms for hospices, mostly government, but, you know, again, payers and just communities that are, you know, supporting us.
Okay. So you do accept donations?
Absolutely.
Well, since we are coming up on year end, it's an opportunity for our viewers to take advantage of some giving before the end of the tax year. If someone wanted to give to hospice, how would they be able to do so?
The best way is to just find us on the website. So www.hospiceofwc.org is the best way. There's great information there on how to donate. We have several ways of donating. One of the things that we do it's a great memorial, we actually sell pavers. If you have a loved one that's passed, not necessarily in hospice, or someone that you want to remember and permanently remember, we have pavers at Dowie's house, our inpatient facility here in Washington County, where we've set up, and we have lots of donors that actually actually buy these pavers from us, and they come by and are able to visit and remember their loved ones. So that's one way, but there's several other ways on the website. Details on how you could do that are there. So,
Excellent. Terrence.
And this is Hospice of Washington County. So is there any relationship to a larger national organization or statewide organization that ties into this?
So there's definitely there's two organizations. The National Hospice and Palliative Care Organization is really the representing body for hospice and palliative care throughout the country. And then we have the Hospice and Palliative Care Network of Maryland, which is the state organization, which we belong to and are very actively involved with. So those are the two entities that we're very close with. There's also another organization, it's called the National Partnership for Hospice and Healthcare Innovation, which is it's an organization that's mostly nonprofit hospices around the country that come together and share best practices and collaborate, and it's all great groups that are helping fuel the energy and the work that we do here in the community.
So what is the interaction with the Maryland and the national organization? What do they provide to you in terms of support, in terms of best practices, anything?
So probably the most important thing that we get from both the national and the state is policy representation. So there are a number of different laws, specifically here in Maryland, that govern how we practice and how we develop hospice programs in Maryland. One of the things that we benefit from is the Certificate of Need laws. And CON laws are important because they allow states and jurisdictions to be able to control the number of hospice programs. In places like Texas, for example, there's 600 hospices, and there could be 100 hospices in a city. Whereas here, we're the only hospice provider in Washington County. And as you look throughout Maryland, you have several programs that maybe share several jurisdictions, but there's a controlled number of programs, and clearly we're serving, we're above the national average in hospice utilization, which is a metric that I mentioned before. So we don't need 100 hospices taking care of the same group of patients. You just need programs that are dedicated to their communities and are willing to serve all patients no matter what, and that's what we represent. And so that organization allows us to ensure that our legislators are informed about these changes, about potential changes that could happen in policy that could affect, that's one example.
Okay.
What they do.
What about, you operate in Franklin County, Pennsylvania too. Are there challenges with operating a 501c3, which I assume that's what you are,
Yep.
across state lines? Are there challenges with that?
There's more challenges. Really, the challenges are around the laws that govern the way we provide hospice in Pennsylvania and Maryland. There are some differences, and so Pennsylvania requires, I would say, more complex licensing and testing and background checking than Maryland does on certain things. And so some of the things that Pennsylvania requires, if you're a Maryland nurse, you can't take care of a Pennsylvania patient unless you have a Pennsylvania license. Mm-hmm. And so there's still some challenges around that. Some states that are grouped together, have decided to come in and allow for those, staff to be able to cross state lines and have, multiple licenses. Pennsylvania's quite not there yet, so that's one of the problems that we've encountered early on. But we work through it. We've licensed our staff. Most of our staff are dual licensed.
Okay.
And that allows us to cross, the line and be able to, provide care on both sides. So.
And does those organizations, do they also govern and put controls in place for for-profit hospice providers?
They do. So, we're all playing by the same rules,
Okay.
and so we have to, there's no differentiation from a regulatory perspective. Both nonprofit and for-profit hospices are measured the same way and treated the same way as well.
So hospice is not exclusively a not-for-profit organization in all cases.
It is not. So, and it's interesting because hospice is a relatively young industry. We're a little bit over 40 years old, and Hospice of Washington County is 40 years old. So we've been in existence since the very beginning. It's the early beginning of hospice in this country. And it started as 100% volunteer movement. Doctors, nurses, social workers that were just wanting to give back. And, the philosophy of hospice care is from the UK, and it came here embraced by several different groups, but not accepted into mainstream healthcare until the early 80s. And so once the government established a payment mechanism, a reimbursement mechanism for hospices, then you started seeing this growth. And then all of a sudden you started seeing volunteer organizations now, mostly nonprofit. Now you've got 70% of all hospices in America, which is about 4,200 of them, are for-profit. So it's been a big change. And for us, we're very proud of our designation as a nonprofit, because we believe that nonprofit hospices are more integrated with their communities. They give back, they do more services, they provide more than for-profit hospices do. And that's a big argument. I think across the board, you'll hear both sides of that equation. But ultimately, you can't argue with the facts that a lot of these programs that are nonprofit have been there for decades. They've been there from the very beginning. They're not running it as a business that if it's not working, we're going to move and go somewhere else. They're committed to those communities. And I think that's the difference that we see. The type of care, the amount of care that's being provided. We all get paid the same. We all are reimbursed in the same way. But it's what we do with our resources, how we extend those resources to patients and families in our communities, that's different. So big shift. And so we've become sort of a minority in our industry of being a nonprofit and operating the way that we do. So.
And have there been for-profit hospices since the beginning, or is that a relatively recent?
I would say that about 10 years ago, we started seeing a big shift. And part of it is it's really the reimbursement mechanism for hospices can be beneficial for organizations if you are very focused on the minimum. So if you provide the minimum amount of services, the minimum number of nurses and doctors visits, and if you focus on that, then there's definitely a profit margin, a significant profit margin. And that's where the challenge is. So hospices, the best way to describe it, when you are in hospice care, you are 100% accountable and responsible for that patient. Everything that patient receives, medication, supplies, anything that patient needs while they're in hospice care, the hospice is responsible for providing. And so that gives organizations, you could say, I'm only going to provide you X, Y, Z, but you may need more than X, Y, Z. And nobody really governs that. There's no mechanism to say, well, there's a minimum requirement, and if you met that minimum requirement, then you're fine. But that's not what we're about. We're not about meeting the minimum requirement. We want to create unique experiences. We want to create great quality, great experience for our patients and families. And so that's the big difference that we see between nonprofits and for-profit hospices. It's the amount and the type of care that's being provided.
Well, and I would also say that you have created a connection with the community that I really don't think can exist in a for-profit situation. Or at least I couldn't see how it would.
You're right. It's for-profits are less connected. There's a lot of venture capitalist dollars in some programs around the country, and if a program is not meeting a certain economic level, they pick up and they sell, they flip those businesses. And so there's a lot of concern around that. It's one of the last vehicles in healthcare where where there's an opportunity to I don't want to use the word manipulate, but sort of influence how much you spend on a patient and how much you can profit from that, from your expenses. So I think that more and more we're going to see the government look a lot closer into these arrangements, especially these big organizations that that are being backed with very aggressive economic goals, to understand how they're operating. And are they really are they shorting the care that they should be providing for patients or not? We have measures in place. We all have quality measures that we're sort of compared across the board, and for the most part, nonprofits operate and perform at a much higher level. Service surveys back to families, our quality measures, everything that that sort of defines hospices around the country. Consistently, we see a much higher performance level for nonprofits.
Yeah. And there's a misconception that nonprofits don't run businesses well,
Right.
which is the furthest thing from the truth. And so I'm glad to hear you break it down and talk about profit margins and having that big picture. As well as being connected to the community as a nonprofit is a benefit. So you kind of have the best of both worlds when you have an understanding of business and running an organization like a business. And most recently, you did something which a lot of organizations have to do right now, post-COVID, is reevaluate about running lean. Mm-hmm. And looking at your footprint, looking at your commercial footprint. You actually sold a piece of property and are moving into another piece of property after identifying some leaner ways to run your organization to make sure that you provide the highest care for your clients. Can you share a little bit about that?
Absolutely. So, during COVID, we've been working predominantly remote with our administrative staff. We have a very large building on 747 Northern Avenue, and for almost 2 years, it's been almost empty, like a lot of businesses. And so we went back and really identified opportunities to be able to sell that building now that the market is really doing a lot better than it was in prior years. And then look at leasing space and really minimizing our footprint and being able to consolidate several locations. When I first got here, we had about 5 or 6 different locations around the county. And so we're condensing that to one, not including Doey's house, but one location where we can run our palliative care program, we can do our bereavement counseling, we can run our operations, and then we have the benefit of being centrally located, making it easier for our staff to connect with highways and get to people's homes faster. So we're excited about that. We just closed on our building last week, and now we're waiting for our new building to be finished. There's some internal remodeling that needs to be done, and so we don't expect to move in until March. But we had an opportunity to sell the building quickly, and we did so. And so we, of course, putting those funds back into the organization and to allow us to do more and be able to run and support our programs.
So we have to talk about Doey's house.
We do.
Tell us about Doey's house.
So Doey's house I would describe Doey's house as just a wonderful benefit and blessing to the community. It's been now 4.5 years since we opened Doey's house. It's an inpatient hospice facility. So the best way to describe it, because everybody asks me this question about Doey's. What is Doey's? What does it do? Is it a nursing home? Is it an assisted living facility? It's none of that. It's what I describe as the intensive care unit for hospice. It's a place where patients that are really struggling with complex symptoms that need 24/7 physician and nursing support are able to come in and be treated. And the goal at Doey's house is come in, get stabilized, and let's get you back home. That's all. That's our goal. And it's not a place where people come to live and die. It's not a place where people come to die. Yes, a lot of our patients are really sick and are coming there and they're at the end of their journey. But our goal is to get them stable, get them comfortable, and then send them back home so that they can be with their loved ones. So it is rare. There aren't many inpatient facilities around the country. It's predominantly nonprofits that actually open up inpatient facilities because it's not a profit center. It's not a infrastructure that's meant to
providing more than what's necessary.
Exactly.
Right.
And
so required, I should say.
But it's tough because it's a 24/7 facility. We never close. The overhead is pretty high, and it's we've got nurses and we have nursing assistants and doctors that we pay to be able to take care of those patients. So it really is a benefit for the community because if not, those patients would probably be in the hospital. We would be taking care of them under hospice inside of the hospital, and so it's a very different experience. And if you ever have an opportunity to visit Doey's house, it's very home-like. It's a beautiful infrastructure. The organization did a wonderful job of creating an environment where people don't feel like they're in a facility. They don't feel like they're in a hospital. And before COVID, we were able to have lots of families come in, sleep in the rooms. The rooms are huge. we have enough space to actually 3 to 4 family members to sleep comfortably in those rooms. And so, when you're talking about end of life and maximizing time, what an amazing opportunity just to be able to spend time with your loved ones, at the very end. That's the moment, the time that, you want to be next to your loved one when they're coming to the end of their life. And so we've created a facility that allows us to do that really, really well.
Going back to the building that you sold, I saw on social media there's an auction, a moving auction that's going on. Can you tell us more about that?
Sure. So, when you decrease your footprint, you also decrease the number of things that you need. So we do have an auction online, and we're hoping to move a lot of the furniture, and there's a bunch of things there that I think people will appreciate and would have an interest in bidding for. So this, of course, all to benefit the organization. Everything that we raise goes back into our programs, and so as we're making this transition, we're not doing it because it's saving us money, but it is saving us money. We're not doing it because it's making us leaner, but it is making us leaner, and so it's a win-win across the board for us. And as we reset our home base and start being leaner, I go back to Terrence's comment about you have to run these organizations like a smart business, because there's no we have a wonderful mission, but if there's no margin, there's no possible way of ensuring that mission continues. And so we take that very seriously, and we're very passionate about that, and we want to make sure that our organization is here for another 40 plus years, and so yes, the auction is going well, and so if you have an opportunity, please reach out. We'd love to.
And there's a few days left.
There's
in the auction.
2 days left.
2 days left.
Yeah.
And how can our viewers participate in this auction?
So if you go to the website, there is a link on the website as well, and you'll be able to link right into the third party that's managing for us.
Okay, excellent.
So you mentioned about 200 volunteers, but you've described this, what seems to me to be a quite large staff. How many providers, how many administrative people do you employ at this point?
So we have about 130 staff members, and that's
Wow.
a combination of nurses, doctors, nursing aides. I mean, the majority of that staff is clinical. We have, of course, administrative staff, and then we also have folks that work in bereavement, fundraising, finance, of course, accounting. It's a pretty large range of different individuals that are supporting different functions in the organization, and so it's a big team, but it's also you have to remember we're taking care of 500 patients, almost 500 patients every day, and so it doesn't it takes a big workforce to be able to take care of so many people and be available 24/7.
Wow.
So what's your vision? What's next?
For us, 2022 is exciting. There's some really wonderful opportunities. We're hoping to continue to grow. We're excited about Franklin County. Franklin Hospice has done an amazing job of just organically integrating with that community. So the way that we designed our strategy has really deployed in that way. And so, just we've been embraced by the community. We've been able to sort of bring our brand into that community and start making an impact. And this is one of those things when we talk about, CON, we talked about certificate of need, and we talked about for-profit hospices. Well, in Franklin County, there are 8 other hospice programs. And so we're number 9, and we've already come in and made a difference. And that's exciting for me. So I'm wanting to see our organization continue to grow and develop there. And we've also talked about expanding into other areas in Maryland. So who knows? There's some interesting opportunities next year, and we're hoping to be assertive and continue to grow, and for the purpose of just ensuring that our organization stays viable and continues to be able to provide the services that we do at the level that we do. That's our goal.
Out of curiosity, the 8 other providers in Franklin County, do you know how many of them are for-profit?
About half of them.
Okay.
Yeah, about half of them are for-profit, and that's one of the things that we see when we decided to go into Franklin County. the first thing we asked, well, we wanted to do some research. Is there a need for another hospice program? Because it's easy. Well, it wasn't easy. Trust me, it wasn't easy just to go across the border. But it made sense. But is there a need in the community? And so I go back to that metric of hospice utilization. We're 56% in Washington County. Well, the hospice utilization rate in Franklin County was 28%. So you think about that, 28% of patients that should be getting hospice, or only 28% of the patients should be getting hospice are getting hospice. And then you have 8 providers that are doing it. So they're not doing the job, they're not doing the work. And so that's why we felt that it was a great extension of our mission to be able to go into that community and slowly start growing organically. We have very little relationship with the hospital systems there. There's 2 hospitals in that community. Because of COVID, they're focused on taking care of COVID patients. There are 8 other hospices. Why do we want to talk to another hospice that's coming in? They're not interested in doing that. Despite that, our reputation, our ability to get to patients immediately, our customer service feedback, they're starting to notice us, and they're saying, well, these guys are different. They're doing it right. They're here when we need you. So, that's how you build, a presence. That's how you build a reputation, is by doing things the right way, and we're extending that into that community from here.
Excellent. Thank you, Ernesto, for joining us today. We wish you a very successful 2022 as we keep moving along.
That's right.
All right. Up next, 3 panelists, 5 topics in 10 minutes. Stay with us for Fast 5. Welcome to Fast 5. Gentlemen, let's get started. First up, Washington County Public School employees must be vaccinated against COVID-19 by January the 4th or be tested weekly. Jim, what say you?
Yeah, so first of all, let us understand that whether or not WCPS wanted to do this, and I don't know that they did or they didn't. I know that there's people that are on both ends of the continuum on this issue.
And it sounds like the superintendent did not want to do this.
That's the way it sounds. Mm-hmm. That said, they really had no choice because OSHA had this ETS, Emergency Temporary Standard, that they put into place. This is based on a lot of dominoes that have fallen over the past 30, 60, 90 days. Mm-hmm. But they really have no choice. They are required to do it. And basically they're required to, all employees either have to be vaccinated, don't have to have the booster. Right. But they have to be vaccinated, or they have to get tested weekly. So, yeah.
And I think, in going for Dr. Michaels, his comments, the superintendent stated that he thought the date would be delayed because the U.S. Department of Labor has delayed the enforcement of OSHA as well.
Right.
So because of the federal, the lawsuits and litigation that's going on right now. Right. So if they have delayed it, he was hoping that there will be a delay for the date for January 4th. So I don't want to say that he's against it, but I think it's still some uncertainty as that's been put out there, because the last, I think, litigation was December 17th, and it was saying it was supposed to go forward. And we know not much gets done the last 2 weeks of December anywhere, right? So I think that's why that January 4th date stays in place. We're seeing right now vaccination. We're seeing what happens right now when we look at vaccination rates across the county, the state, the country, worldwide right now, what that impact is. And we've now recently gotten a vaccine for our youth. So I think there's a lot of things moving right now that says that this is the best direction to go in, especially since there is an alternative. If you don't want to get vaccinated, then you get tested. Right. So no one's being forced to get vaccinated. No one's job is being threatened. Is it an inconvenience? Absolutely, that you have to get tested weekly. But if you decide to get vaccinated later on, then you immediately stop getting tested. So that's the incentive there. But I don't think there's anything punitive here other than the inconvenience of going and get tested to ensure that when you come into an environment that you don't have COVID when you're someone who is not vaccinated. So I don't see a major issue with it, but I know that there's lawsuits across the country right now, especially by some educators,
who feel that they shouldn't be forced to be vaccinated, especially since all of the children haven't been forced to be vaccinated right now at this point.
Yeah, so if we look at this issue as a one and done issue, I agree with what you said. That notwithstanding, I see this as more of a precedent, and I'm struggling in my own mind to figure out what the precedent it sets and what is the next thing that's going to say, well, we did it for COVID, right? And I don't know what that is. And that might be something that I care a whole lot more than whether I have to get tested for COVID. And again, I'm vaccinated, so it wouldn't be an issue for me.
But the precedent was set when you went to school, because we've had vaccination mandates on children for decades, right? You can't come into the school system unless you're vaccinated. So the precedent has already been there.
There's a good argument there. I'm not arguing that. But again, I think this is in a lot of people's mind a very different issues, because this is not about, this is one that the adults got first and the children are getting second.
Well, this one got wrapped in politics from the beginning, so obviously it's, this comes down as mandate from federal government, and whatever mandate federal government, that everything's off the table.
This comes down to the distrust in government, because you go back 50 years and the government makes this mandate, it's not a problem. I'm sorry. We've gotten to the point where we don't trust the government, we don't trust the decisions, we don't want them involved in our lives, and we're pushing back, and we've been given tools like social media to do it. We don't murmur about it amongst our friends that, we can go right out to the public and share, and we can pump information into individuals, whether it's correct or not, and we're in a different time where the things that the government once did will never be enforced the same way because of the access to the internet.
But again, as you said, the vaccine is not being mandated. It's a heavy incentive.
It is, yeah, for sure.
That's there.
Yeah.
So,
all right.
Next topic, Governor Hogan provides state funding of $100 million in emergency funding to increase staff at hospitals and nursing homes. Terrence, what say you?
It's necessary. Unfortunately, it's not going to solve the issue. I think most of this money is going to be pushed towards resources and testing. It's not increasing staff. It's not compensating staff.
Well, it's stable. The term he uses, they're committing $50 million to stabilize workforce and staffing needs. I'm not sure what that means.
Yeah, I think that's, is it going to be a retention bonus that you're going to get to individuals? These individuals are exhausted. It's been almost 2 years of being worked at 80 hours for some of these doctors a week.
Right.
Yes, they're getting time and a half. They're getting double time pay, and that money has to come from somewhere. So I think that's where it's going to be. It's going to, balance some of the budgets of some of these hospitals that are having to pay some of these staff. But I don't think it's bringing in new staff. I don't think it's doing the recruiting. I think it's compensating and retaining those who are already at the brink in some cases as well.
And the doctors and nurses have been victim of the great resignation as well. So we have doctors and nurses and others, according to what I've read over the last months, that have decided to just hang it up early.
Yeah. So, and it's, supply and demand. The demand is high, but the providers are decreasing gradually. Our hospitals, need this because we're being flooded, and we've seen this with the new variants of COVID. So we have more people coming in the hospital. The need is greater, and yet, we've gotten to the point where we've exhausted the human resource, where doctors and nurses and other healthcare providers are pressed against the wall, where they're stepping away from the field, going elsewhere. So I'm not sure throwing money at it is the answer right now without some kind of strategy instead of a vague statement of like stabilization.
Yeah. Well, and he's also, in addition to the $100 million, they're providing $30 million for schools for testing kits.
Yeah.
So back to our last topic.
Some of the numbers that were in this article, this article is from the 21st.
Right.
And, the state's positivity rate, COVID positivity rate was at 12%. I believe this is about 16%. And Washington County, we're at 19%. So we're
Means
not
one in
in a good
five.
place. Yeah,
That's not good.
not good.
We had 5 people in this studio tonight. Statistically,
And that's what it is. And we've seen it. I've over the last 2 weeks, how many businesses has had to close early for the holidays?
Right.
How many, and there's a big push to do not have New Year's parties. I think one of the things that we came into this season, not with the same controls and warnings that we had last year because of the vaccine.
Right.
So I think a lot of people moved differently this year
They
around
certainly
the
did.
holidays, which caused, a spike. And we see it every year with the flu, stomach viruses. We see it consistently at this time because we're more exposed and interact with each other, and we travel from state to state. I hate to think that this is going to be the new norm. That we will see spikes like this around this time of year every year, and we can't be reactive from an economic standpoint as we once were, because we're going to have to pay that price.
Yeah, and just on a local level, it's been a little unfortunate to see how COVID has become rampant in winter sports programs.
yeah, absolutely.
A lot of canceled sporting events the last couple of weeks, and club volleyball and things like that. That it's been an issue.
Yep.
So. Next topic: Maryland's new congressional map draws first legal challenge, and it looks like one of our local Republican General Assembly members is spearheading this, Mr. Neil Parrott.
Yeah.
Terrence, what say you?
First of many, all right? That's what I can say, first of many. And, you think about, the problem with the maps now came out of the last census in 2010, right? We're going to 2022, and now we're at this finish line to force it in and put these committees together, and everyone draws their map. Everybody gets a crayon. Everybody gets a map. Color it in. What works for you? That gives you 2 Republicans. To bring that down to 1, it's ridiculous. This is what I'm talking about, the not having trust in the government. This is embarrassing. And for them to be attacking one another based on whether it's Republican and Democrat, and that's what's best for the voters, because when they asked the voters what was best for them, they threw that out the window, right? And when the voters were able to chime in on what the map should look like, it didn't work. Right, so they force this map in that 90% of people don't know about, don't care about, don't understand, but it impacts their lives every day.
Tremendously.
Every day.
And a nonpartisan commission gave our map what grade?
It was an F.
An F. A good solid F.
Yeah, it was kind of like that red F that's on the paper, when your
Exactly.
teachers.
And how long has that map been in place?
Yeah, not long. So, yeah, I think this is going to be the first of many. I think that, frankly, I think it's like spitting in the wind. I don't think there's a snowball's chance that we're going to get it changed, but whatever. Yeah, it's a sad reality of politics in the 2020s.
The problem is that state by state we're having these issues. Like
Right.
there's not a national standard.
Right, and we're having these issues on both sides.
Right, absolutely. Depends on the state.
Yeah. So
And the federal court said there is not a place to bring these issues to them. They said handle it at home.
right.
But now we're trying to take this one federally.
Well,
again.
they're waiting until it's so egregious that they have to step in, and yeah,
Who suffers?
yeah.
The voters.
Exactly.
The voters. Well, as we always say, we'll talk about that again. More for you. This article is about a gentleman that was on a call with the president and the first lady.
A Christmas Eve call.
A Christmas Eve call for his
Right.
son.
for his son, and apparently he's not a Biden fan.
Right. So the call was cordial, right? Normal call, and then he gets to the end and he says the magic words,
Let's go,
Brandon.
Yeah. So first of all, that guy, I would bet, knew that this was going to go national. And I think he's loving every minute of it.
Oh, absolutely.
I think the best thing we can do here is ignore this kind of crap. people are going to say what they're going to say, and you can't swing at every pitch. You know what? I think I am not a Joe Biden fan, but I agree that it was juvenile, it was disrespectful, and it was classless. I think regardless of who our president is, they are our president. And you can walk around and say, not my president, whether it's Donald Trump or George Bush or Bill Clinton or Joe Biden, but they are. If you're an American citizen, they are your president. And I think the office deserves some level of respect, whether you agree with them or disagree with them. And it sounds like he was 100% cordial.
Until
I'm sure he is cordial. Whether we like his policy, whether we think he's fit for service, is a completely different issue than whether he is a decent, upstanding member, decent, upstanding human. And I think he is, from what I've seen.
I agree, and the fact that this parent is now feeling attacked for using.
He's not feeling attacked. He's laughing all the way to the bank.
Absolutely, and that's my problem here, because he invoked the First Amendment again, right? And we had this conversation last
His First
night.
Amendment is not being attacked.
Right, and it's not being attacked. First of all, if you want to say that your First Amendment is being attacked, learn what the First Amendment is, right? Because he's being attacked by other people exercising their First Amendment rights, not the government putting controls.
And isn't that the First Amendment? That you can say what you want that is something completely opposite to what I would say, and I can say what I say.
Right.
That's the whole point.
Now, if I said something and the government tried to silence me or stop me from saying it, now that's an infringement on my First Amendment.
Yes.
That's different. But if I give my opinion and you give your opinion about me giving my opinion, that's consequences and accountability. And that's what this person right here needed to take some accountability. And the fact that he had a YouTube page recording it and with a hashtag and then used this to go on an interview circuit, he didn't want to stay anonymous.
Yep.
Let's just say that.
Well, he got what he wanted, right? He ended up on Steve Bannon's podcast. He was celebrated by, the party that he is in favor of. So he got everything that he wanted out of this moment.
Yep.
Including exploiting his child on Christmas Eve.
Yep.
Well, he knew this opportunity was coming, and he utilized it the way that he saw fit.
Yep.
Poor kid.
Yep.
Last topic, gentlemen. Lottery vending machine. Mistake earns a Maryland woman $50,000.
Not only a Maryland woman,
A Hagerstown
Maryland woman at the halfway liquor store. I have been to that establishment before, maybe in the last couple of weeks.
Terrence probably has too.
I wish I put the wrong button.
Well,
my problem is I've been pushing the
that
right button.
That is the story. She meant to push for one ticket. She pushed for the other
Right.
ticket, and she won $50,000. That's a happy error. So
That is
congratulations
a
to her.
happy holiday era.
She's 43 years old. She invested $5, or at least that night she invested $5. Because let's face it, you got to play to win, but you got to play to lose too.
Yeah.
Right.
But she invested $5 and she won $50,000. That's pretty good ROI.
Absolutely. Good for her. Good for her.
So.
I'll never know because I never play. So.
I don't either.
I only play when I get angry. Like, I got to get out of this place, and I go play a lot of because I want to live on a beach somewhere. But I'm not consistent myself.
All right. Well, that's all the time that we have for tonight. We hope that you'll like us on Facebook, follow us on Twitter, and send us your comments to feedback@theflipsidetv.com. That is feedback@theflipsidetv.com. Most importantly, we hope you'll join us again next week for another episode of The Flip Side.